Okay, so now I'm going to talk a bit about the emotional and behavioral issues that are associated with adult TBI. In general, brain injury greatly increases the risk of developing neuropsychiatric symptoms, and this is both due to the organic effects of the injury itself, as well as to reactive distress caused by having a significant injury. The profile of injury generally predicts what neuropsychiatric symptoms exist. Here is a list of psychiatric syndromes common after a TBI, with the percentage of patients that experience difficulty in a variety of domains after 7.5 years and then after 30 years. You can see a variety of psychiatric symptoms are common after TBI. Symptoms appear to improve over time, but even after 30 years remain significantly higher than what is seen in the general population. In addition, approximately 60% of patients that have had a TBI experience coexisting symptoms of anxiety and depression. Specifically with regard to depression after TBI, major depressive disorder is present in approximately 40% of hospitalized TBI patients. The fact that these patients are hospitalized assumes that they are likely victims of moderate to severe injuries. Typically, patients are not admitted to the hospital after a mild TBI. During the first year after a TBI, 33% of patients were shown to be depressed with risk factors including poor executive functioning as well as premorbid depression, a left dorsal lateral frontal lesion, and/or a left basal ganglia lesion. Moderate to severe depression has been shown to range from 31% at 1 month post-TBI to 17% at 3 to 5 years post-TBI, significantly above the general population. In terms of anxiety after an adult TBI, generalized anxiety disorder in the general population is estimated to be about 5.1%. Generalized anxiety disorder after TBI is very much debated. Some research shows that there is a lower prevalence of anxiety after TBI at 2.5%. Other research shows a higher prevalence at 10.2%. This discrepancy is probably associated with the patient's awareness of disability. Patients that have a milder TBI likely have awareness of their deficits and have a lot of concerns about the future and their ability to support themselves. However, those with a more severe TBI are unaware of all their deficits, so don't show anxiety. The pathological absence of anxiety is associated most likely with frontal lobe functions and severe deficits. Psychosis after TBI is uncommon, but it has been observed. Schizophrenic-like disorders are 2 to 3 times more common in patients with a history of TBI. However, you need to consider the base rate of these symptoms in the general population, which is very low. So 2 to 3 times more common is still relatively rare. When present, these symptoms may be due to frontal lobe damage, impaired self-awareness, or premorbid factors. Risk factors for psychosis after TBI include a left hemisphere injury, more severe injury, and prior injury to the central nervous system. Again, premorbid characteristics might contribute to having a prior central nervous system injury. It may be that premorbid characteristics make individuals more prone to have a TBI. The typical approach to treating psychosis after a TBI is an atypical antipsychotic trial. If that doesn't work, a second atypical antipsychotic trial is typically administered. If that is still ineffective, typical antipsychotics, ECT, or other behavioral treatments are often implemented. Several other emotional problems are common after a TBI that reflect both the organic insult of the injury itself as well as the reactive distress factors. One common problem that's reported is a lack of empathy. About 60% of patients with a TBI are reported to have a lack of empathy compared to 31% of control subjects. This is reported to be due to damage to the prefrontal cortex and the right posterior cortical regions, but there's likely both an organic contribution to the psychological disturbance as well as potentially reactive distress of the TBI. Irritability is also a very common emotional problem after a TBI, with 37% of TBI patients ages from 18 to 65 reporting it. This is linked to disinhibition and frontal lobe deficits, but again, it has both this organic contribution as well as irritability because they're adjusting to a much different lifestyle than they had prior to the injury. Socially inappropriate language is another common emotional problem, which is not just disinhibition. It's reported to be due to bilateral frontal lobe dysfunction with impairment in self-awareness, but stress and frustration related to adjusting to the injury are also likely to contribute to a patient's socially inappropriate language at times. As I mentioned, agitation and irritability are probably the most common complaints identified by patients and spouses of patients with a TBI, independent of the severity of the injury. These symptoms are most likely related to tiring more easily, trouble following conversations, and difficulty adjusting to a different lifestyle. Oftentimes, symptoms that are primarily organic in nature manifest as anxiety and depression. For example, hyperarousal and agitation may manifest as anger and combativeness, and uninhibited movements and restlessness may manifest as anxiety. Later during recovery, as the patient continues to improve, fatigue and sleep disruption may manifest as depression. So you really need to be able to distinguish what is an organic symptom that could be treated with organic means, or an emotional symptom that should be treated behaviorally. In terms of recovery of premorbid psychological status, patients with a moderate TBI generally report greater difficulty than those with mild or severe injuries. Again, this is represented by a bimodal distribution. The patients with mild TBI report less emotional or behavioral changes due to a lack of significant injury, whereas patients with a severe TBI report less behavioral changes or emotional problems due to a lack of awareness of the problems. Over 1 year, there is typically improvement in cognitive clarity, dysphoric mood, and emotional stability, but often more difficulty with anger management, antisocial behaviors, and self-monitoring. It may be that when the patients with moderate to severe brain injuries become reintegrated into society and their cognitive problems begin to influence their performance more, they have difficulties managing their anger and often act out due to their difficulties monitoring their actions. So what helps protect against psychological dysfunction after a TBI? One important psychosocial protective factor is preserved problem solving, particularly executive functioning abilities. Perceived social support is also crucial, and here you need to differentiate between actual levels of social support that the staff from various facilities or family might see and the perception of social support that the patient feels, because it's truly the perception that the patient has that's important as opposed to the actual level of social support. Perceived social support has been shown to predict 10% of the variance in life satisfaction score, and less caregiver distress has been shown with increased levels of perceived social support. Positive affect is another important psychosocial protective factor. Patients that have more positive affect, more hopefulness, are shown to have improved recovery. In addition, psychosocial factors such as strength of character has been shown to be important, particularly characteristics such as bravery, humor, spirituality, and kindness, which I'll touch on in just a minute. Now I'll present some information related to treatment of psychological problems after TBI. In general, treatment after TBI is quite similar to any other psychological treatment, but a few things need to be kept in mind. Most importantly, you need to keep in mind sources of rater bias. After a TBI, patients and their relatives may not give a completely accurate representation of patient functioning. Relatives may overestimate problems due to stress or may underestimate problems due to denial. Relatives also have a tendency to overpathologize the patient and overestimate the patient's premorbid level of functioning. Patients themselves, like we talked about, are frequently unaware of their deficits and may therefore misrepresent what they can and cannot do. The presence of mood disorder is very common after a TBI and affects both long-term social and functional recovery. There's no controlled psychopharmacological agent studies of mood and anxiety in TBI at this time, but SSRIs appear to work best with the least amount of side effects. There are many types of psychotherapy treatment that are shown to be effective in adult TBI. I will cover 3 of them. The first is cognitive behavioral therapy. It has been shown that symptom attribution is the primary element in the maintenance of post-concussive syndrome symptoms in patients with mild TBI. So cognitive behavioral therapy with this population focuses on this concept. Building on this finding, Ferguson and Mittenberg in 1995 developed a 12-week outpatient treatment protocol for patients with mild TBI that incorporated 3 things. First, they educate the patient about the typical recovery from mild TBI and help the patient understand that symptoms are maintained and intensified by anxiety, negative cognitions, and misattributions. So they introduce the classic cognitive behavioral therapy model, suggesting that negative cognitions contribute to the maintenance of symptoms. In addition, their treatment protocol teaches coping skills, cognitive restructuring, and stress management techniques. Finally, patients in this treatment program are encouraged to resume pre-injury activity level through the use of activity scheduling. So basically, very common cognitive behavioral and behavioral therapy techniques are used in this population and is shown to be quite effective. A second type of psychotherapy that's been shown to be effective is simple social support. Social support has been shown to be the best predictor of family functioning after a TBI, and it is a powerful moderator of caregiver psychological distress. As caregiver psychological distress is a good indication of patient functioning and functional recovery, social support may play a crucial role in family functioning and patient recovering following a TBI. Mentor programs in particular have been highly recognized as effective interventions after a TBI, enhancing the academic and vocational success of these patients. Interventions have been particularly effective when the mentor is a peer who shares a similar characteristic with the patient. So peer mentorship programs where the mentor has also had a TBI are particularly useful. The third type of psychotherapy that's shown to work well with adult patients after a TBI is positive psychology. In positive psychology, which is a growing field now, patients are encouraged to explore their character strengths that contribute to recovery from TBI. As opposed to focusing on the problems that the patient has, as typical psychotherapy often does, positive psychology focuses on character strengths and how those character strengths can help functional, emotional, and potentially cognitive recovery. Particular character strengths that are explored in positive psychology include the strengths of bravery, humor, spirituality, and kindness. The last thing I want to talk about today is family functioning after a TBI. I wanted to broach this subject because family functioning is crucial to the patient functioning and the patient recovery. Brain injury has been shown to be one of the most difficult situations to which a family must adjust. Contributing to this adjustment are the survivor's neurobehavioral disturbance. In fact, the neurobehavioral disturbance of the person with the injury has been shown to be the strongest predictor of caregiver distress. Also contributing to family adjustment is the burden of care that the caregiver experiences, as well as the disruption of the patient's family patterns of relating to each other. For example, when an adult patient becomes childlike in their demeanor after a TBI, it can obviously disrupt the pattern of functioning within the family. There are a lot of extra patient factors that also contribute to family adjustment that a lot of people forget about, such as the financial impact of the injury, changes in family planning, community access problems, time economy issues, environmental modifications that need to be made, difficulty obtaining treatment, particularly in rural areas, and the emotional status of other family members in response to the injury. The point to remember here is that patient functioning affects the family, and that family dysfunction affects patient recovery. There's an increased incidence of anxiety, depression, and adjustment difficulty in family members of patients with a TBI due to a disruption in the pattern of functioning within the family. Survivors of TBI with an unhealthy family dynamic have demonstrated less improvement on the disability rating scale at 5 months post-TBI, especially on the level of functioning score, and the employability score indicating that they're less likely to return to work. Just as pre-injury factors are important in determining a patient's cognitive and emotional recovery, pre-injury factors are also important in determining a caregiver's ability to respond to a TBI. In 2001, research showed that a caregiver's pre-injury health and psychiatric status was the best predictor of caregiver function at 1 year post-injury. Other research has shown that 41% of caregivers had depression prior to a loved one's injury, and the majority of caregivers that were depressed at 1.5 years after a loved one's injury were those that had pre-injury depression. Burden of care is also a significant psychosocial stressor affecting caregivers. Frequently, the stress of psychosocial issues is more impairing than the physical demands of the care that the patient with a TBI demands. Burden of care is influenced by the survivor's neurobehavioral disturbance, the survivor's social isolation, and therefore the caregiver's social isolation and loss of social connections. The changes relating to family functioning and, of course, the physical dependence that the patient with TBI requires are also significant causes for stress for the caregiver of a patient with TBI. The ability of caregivers to navigate these issues is crucial, as caregiver status is a good predictor of patient outcome. There are 4 models of working with the family after a TBI. The first is the developmental model, developed by Turnbull and Turnbull in 1991, in which the response to the family depends on family characteristics, interactions, the functions the family needs, and where the TBI happened in terms of the family life cycle. So the entire family is involved, and the developmental status of the family is the integral part of this treatment. Also effective in terms of family interventions is multifamily group support, which includes both peer-facilitated groups, group psychotherapy, and peer mentoring. Tasks in the family support model of psychotherapy include exposing families to role models of adaptive coping, providing long-term reliable support, education regarding available resources, and provision of extensive support and assistance during time of crisis. The final 2 interventions to aid family functioning after a TBI are transitional planning, in which clients attend psychotherapy only when they're experiencing a life transition, and systemic therapy, in which the psychotherapist intervenes to change the structure of the family and not just treat the patient per se. This involves joining with the family, reframing situations, and enacting a different, more adaptive scenario. It then involves reinforcement of appropriate behaviors. In summary, important things to remember when working with adults with a TBI include, number 1, understanding the type and severity of injury to know what should be expected in terms of patient functioning. Number 2, assessing the premorbid characteristics and ruling out other sources of patient dysfunction. And 3, preparing for deficits that are most likely, including difficulties with attention, memory, processing speed, and executive functioning, and setting up behavioral plans to compensate for these cognitive deficits. Psychologically, it's important to, number 1, evaluate for mood disorders that are common after TBI, particularly depression and anxiety. Number 2, assess family functioning and the level of patient support. And then, number 3, treat these mood disorders as you would treat most other psychological disturbances using validated treatments. By keeping these basics of TBI in mind, family members and those that work with adults that have had a TBI can best respond to these patients' needs and hopefully improve their quality of life.